Good afternoon. The subcommittee will come to order. I want to welcome our witnesses to discuss the results of the Oracle Cerner EHR implementation at the Captain James A. Lovell Federal Health Center in North Chicago. Lovell is the first only fully integrated VA Department of Defense healthcare facility in the country. It's also the first large complex medical center where VA and Oracle have installed the EHR system. Secretary McDonough approved the go-live on March the 9th as an exception to the overall pause on the electronic health record modernization program that's been in place since October of 2022. That was despite the reset effort not yet producing any game-changing improvements, despite the VA pharmacy organization's objections, and despite the facility not completing its infrastructure improvements. The results at James A. Lovell tell us a lot. I want to thank Dr. Buckley for traveling here today to help us understand the reality of the situation. The reality is, this is the same system with the same problems that we have seen elsewhere. I commend Dr. Buckley and his team for how well they have managed the challenges, and I'm glad other parts of the VA have been able to flood the facility with the resources that are necessary just to keep the thing functioning. Their ability to work around the problem is commendable, but make no mistake, despite all the spin, the problems have not disappeared. And as a large, complex medical center, Lovell has revealed new flaws in the Oracle Cerner EHR. The committee staff visited James A. Lovell twice, and the employees are reporting the same frustration, hypervigilance, and burnout that the managers at the other 4 facilities testified about last September. They've managed to keep the doors open and provide care to the veterans and service members, but only with the support from more than 100 new staff and nearly 100 more on the way. In addition to the new staff, there were nearly 800 experienced users from other military treatment facilities, contractors, and experts from the VA central office pitching in immediately after the go-live. The pharmacy is completely reliant on outside help to operate. The Oracle Cerner pharmacy software functions so poorly that the permanent pharmacy staff can only process about 40% of the prescriptions. They're relying on the VA supplemental staffing unit to handle the majority of the workload. This has all been feasible at one facility, but no one thinks it's repeatable or sustainable. I have serious concerns that the Secretary McDonough is about to put the Department of Veterans Affairs and the veterans it cares for in a dangerous situation by resuming the go-lives on a large scale. If VA is not able to or willing to provide the same level of support they did for James A. Lovell at other medical centers, the result could be a disaster. Everyone needs to think seriously about that risk. The Oracle Cerner EHR is simply not good enough today to enable a bare minimum of efficiency at the VA, let alone the high-quality care our veterans deserve, without a huge influx of extra staff and money. Even before Ms. Duke disclosed that the Veterans Health Administration is facing a $12 billion budget deficit, the financial impacts of the EHR on the organization's staffing have never been budgeted or seriously reckoned with. You can see, we have known for 2 years that the VA's cost estimate is unlikely to hold. But despite everything that has happened, we still hear rosy predictions from the VA and Oracle, and no one has acknowledged the true cost from Mr. Cecilia and Dr. Adiram. They still are professing that this is going to be a $16 billion project, and we know it's not. We've learned from Lovell and the previous facilities that the expense to purchase and install the EHR is just the beginning of the cost. I have no doubt that moving forward with the system before it is fully functional and before the productivity and safety problems are resolved is the wrong decision. It is wrong for the veterans, and it is wrong for the VA employees. The Secretary is clearly no longer heeding my warning or this committee's warning. Therefore, the only responsible course of action is to lay out the true cost of finishing the Oracle rollout before the VA commits to it. Veterans and taxpayers deserve to know how large the Oracle Cerner bill truly is. Congress, as well as the public, need all of the information in order to make an informed decision about whether this is worth it and whether the inevitable sacrifices are truly justified. Anything less is a dereliction of duty. With that, I yield to the Ranking Member, Sheriff McCormick, and her opening statement.
Thank you, Mr. Chairman. And I thank you for our witnesses for being here today to discuss the things are going on at VA's newest Oracle Health site, the Captain James A. Lovell Federal Healthcare Center, or FHCC. It's been just over 4 months since FHCC went live with Oracle's Millennium EHR. By many accounts, this go-live has been VA's most successful to date. While it may have been more successful than previous attempts, I think we are far from ready to endorse further go-live activities. FHCC had the luxury of being the sole focus of both VA and DoD's EHR modernization programs. The two departments threw more resources at this go-live than will ever be available at any future VA facility. Regardless of how successful the implementation at FHCC may have been, there are still many issues that need to be addressed. We recently learned that the pharmacy fixes Title 3B and 3C will not be rolled out until spring of 2025. These are meant to address issues that were identified years ago. We've heard from pharmacy managers that without these fixes, the workload required to keep veterans safe is unsustainable. I would really like to understand what is taking so long to get these issues fixed. Another longstanding issue, it's been 4 years since the first go-live at manned grant staff, and training and change management are still not meeting expectations. VHA staff are still not brought into the standardized workflows and are trying to modify the system to match what they are used to. I reiterate my concerns that the VA is still attempting to standardize its workflows and equipment and standards while they are actively deploying a new EHR. This really should have been done first, and I suspect it will continue to cause problems with the deployment until these standardization decisions are made. Also, the facilities using Millennium are still far too reliant on workarounds. I'm concerned that the need for workarounds indicates that their systems still isn't fully functional or staff are refusing to use the system as designed. I'd like to know which one is it. It also seems like the workarounds are not being centrally managed. I've heard that staff at individual facilities are creating their own and not communicating them up through the EHRM IO. I fear we are headed for a situation where every facility is using the system differently, which is contrary to the standardization goals of this project and runs the risk of continuing the reality that if you see one VA, you've only seen one VA. We really should not allow that to happen. Fractured or segmented care is not in the best interest of veterans. Since FHCC is the first level of one VA facility to go live with the new system, there are new issues that have been raised. Specifically, there are several issues that FHCC staff raised that upon further investigation came down to providers not entering orders correctly, which is creating way more work downstream for the lab, pharmacy, and referral management. I would like to understand why this continues to be an issue and what VA is doing to fix it. I suspect that's something to do with providers' complaints that the system is not intuitive and that it's not user-friendly, and that it takes far too many clicks to accomplish their work. I'm concerned that Oracle doesn't seem to be acknowledging these complaints and addressing their usability shortcomings. This is not a new complaint. EHR users have had these complaints for almost as long as EHRs have existed. But this lack of usability has caused VA to need to hire considerably more staff to accomplish some of the same tasks. I'm concerned that these extra manpower needs will have a dire impact on VHA's budget, that the need for facilities to hire more people to do the same task will limit their ability to fill other vacancies. This could have a disastrous effect on veterans' access to VA healthcare and will lead to further expansion of community care. We cannot allow this to happen. There are valid reasons for community care, but understaffing should not be one of them. It is our responsibility to ensure that there is a VA for future generations of veterans. For us to do that, Oracle must take a hard look at how overly cumbersome its system is and solve the usability issue. I look forward to hearing from our witnesses today, and I yield back.
Thank you, Ranking Member Surface McCormick. I will now introduce the witnesses on our first and only panel this afternoon. First, from the Department of Veterans Affairs, we have Dr. Neil Evans, the Acting Executive Director of the Electronic Health Record Modernization Integration Office. We also have Dr. Robert Buckley, the Director of the Captain James A. Lovell Federal Health Care Center. Next, we have Ms. Laura Duke, the Chief Financial Officer of the Veterans Health Administration. And finally, we have the Honorable Ms. Seema Verma, Executive President of the Oracle Health and Oracle Life Sciences. I ask the witnesses to please stand and raise your right hands. Do you solemnly swear under penalty of perjury that the testimony you're about to provide is the truth, the whole truth, and nothing but the truth? Thank you, and let the record reflect that the witnesses have answered in the affirmative. Dr. Evans, you are now recognized for 5 minutes to deliver your opening statement.
Chairman Rosendale, Ranking Member Sherfield McCormick, and distinguished members of the subcommittee, thank you for this opportunity to testify again today about VA's initiative to modernize its electronic health record system. I'm accompanied, as was just mentioned, by Dr. Robert Buckley, Executive Director of the Captain James A. Lovell Federal Health Care Center in North Chicago, Illinois, and Laura Duke, Chief Financial Officer for the Veterans Health Administration. I want to thank Congress and this subcommittee for your shared commitment to veterans and for your continued support of VA's modernization efforts. As has been mentioned today, we're here to discuss the deployment of the federal EHR to Lovell FHCC, our progress with the EHRM program reset, and VA's plans to move towards restarting deployment activities in the coming year. As you likely recall, the current EHRM program reset was announced in April of 2023 with 3 primary goals. Number 1, to address the concerns of the live sites. Number 2, to invest in foundational work necessary for long-term success of the program at the enterprise level. And number 3, to prepare for and successfully deploy the federal EHR at Lovell FHCC. A little less than a year after that announcement, in collaboration with our partners in DoD and the firm, VA realized one of those goals by launching the EHR at Lovell FHCC on March 9th, 2024. We continue to support and closely watch progress at Lovell FHCC. At this point, it is still too early to declare unequivocal final success, but results have been promising overall. There have been no critical patient safety incidents as of today. Lovell FHCC maintained 100% capacity for its emergency room and inpatient bed census throughout the deployment. Outpatient productivity is up to approximately 80% from a 50% reduction for go live, and acute medical and ICU care has returned to baseline. The leadership and staff at Lovell FHCC should be commended for their success. They've demonstrated tenacity and a continuous commitment to successfully adopting the new electronic health record to care for the veterans, Navy recruits, DoD beneficiaries, and others who are served by their organization. Progress towards achieving the other 2 reset goals, addressing issues identified by the live sites and improving our enterprise processes to support the federal EHR, continues. For example, more than 1,500 configuration changes have been implemented in the past year to improve the experience of end users at the live sites. From July of 2023 through May of 2024, VA resolved more than 1,000 aging incident tickets and resolved the vast majority of its provisioning backlog. We've seen the core EHR increasingly stabilize, resulting in significant improvements to the user experience. We were able to introduce new methods for training users as part of the Lovell FHCC Go Live, which were well received and are informing further changes in our training and adoption approach. a new process for effectively managing configuration changes for the system, one that will better support adherence to best practices for use of the EHR, enforce adherence to national standards, and better leverage our informatics workforce at both the site and VISN levels is currently being implemented, and more. While we've seen measured and meaningful progress, several improvements that are important for long-term success require revisiting decisions made early in the program through the lens of lessons learned by the DoD, VA, and the best practices of other Oracle Health customers. These projects are more significant than a simple fix and are being referred to as big rocks, given our prioritization of these efforts and because of the complex scope of the tasks. Some of these involve revisiting the approach to referral management, further improving training for new users, standardizing and consolidating user roles in the system, delivering a key pharmacy capability known as Pharmacy 3B, 3C, and more. In parallel, other reset work streams continue with their focus on process improvements that will support the Big Rock efforts, increase the pace of change, and move the program towards restarting deployments. Although it is still too early to discuss concrete plans for resuming deployments, VA remains committed to exiting reset and restarting deployment-related activities in FY25. I should emphasize, however, that the continuous improvement efforts that have been our focus during the reset will continue even after we restart deployment-related activities. Our restart is not a binary toggle from improvement efforts to the pursuit of deployment efforts, but instead is additive. We'll restart deployments while we continue, that is deployment activities, while we continue our support for our current users and our system optimization efforts. Wrapping up, with the activities now underway and considering our progress to date, VA leaders are optimistic about a path forward towards full implementation of the federal EHR throughout VA, and we appreciate the partnership of Congress as we pursue that goal. Thank you for your commitment to serving veterans with excellence and for your interest in and oversight of this program, and we look forward to responding to your questions.
Thank you, Dr. Evans. The written statement of Dr. Evans will be entered into the hearing record. Dr. Buckley, you are now recognized for 3 minutes to deliver your opening statement.
Thank you, Mr. Chairman. I was not asked to actually prepare formal written statements, so I'll take this opportunity, though, to thank everyone and say this has been a great opportunity on behalf of the Captain James A. Lovell Federal Healthcare Center. As you mentioned, our nation's only fully integrated defense and veteran healthcare agency that's led by the Department of Veterans Affairs in that partnership. This opportunity to have a single integrated electronic health record is the opportunity that this facility has been waiting for close to 15 years. And we have benefited from it already in many ways. There's certainly been challenges along the way and opportunities to learn from, but I can tell you this, our staff understand the value that brings to all of those entrusted to our care, to our veterans, but also to all those that will someday be veterans and in their family members as well. I can tell you, I would characterize our journey so far. I'm going to say it's going very well. I'm going to say it's going better than anyone expected. And I'm going to say that because we have phenomenal staff. We have staff that are committed to being a high reliability healthcare organization, to use whatever tools we need to make sure that our patients get the very best care possible. And we are leveraging this new electronic health record to make sure we meet those ends. We're also my staff are also fully focused on becoming the facility, the first 1C, level 1 VA medical center, and the only, as I mentioned, joint DoD and Veterans Medical Center, to have the opportunity to learn how this new electronic health record functions, learn the workflows, learn the technical aspects, that many that still need to be improved, certainly, I agree with you. So I would just say that our people are to be commended, our staff, I believe, are to be commended. And then our partners, we've had great partners, and when I mean that, I mean from within the VA itself. You mentioned there's been a lot of support that we've gained, a lot of short-term staffing support that has really been helpful for this particular unique deployment that had lots of things that needed to be addressed. It's good to have that extra subject matter expertise at your side when you go through this, and we've benefited greatly by the support that we've gotten from within the department. and within the DoD as well. There was a lot of great support across the departments. And then finally say our partners at the Oracle Health, Cerner, Federal EHR, our Oracle partners, I think, are really starting to show some signs of improvement and being attentive to some of our needs to change for both engineering changes as well as just changes to configurations, and then the assistance to help our workflows become better and better. So with that, I think that's kind of our take on it so far, sir.
Thank you very much. Ms. Verma, you're now recognized for 5 minutes to deliver your opening statement.
Member Sherfilis McCormick and members of the subcommittee, thank you for the opportunity to speak with you today. This is my first time to appear before this committee since joining Oracle. I took over as the general manager of Oracle Health at the beginning of the year, and I'm very pleased with the progress we have made, not just this year, but overall in the 2 years since Oracle's acquisition of Cerner. As general manager of Oracle Health, I'm excited about the opportunity to bring a higher level of quality, efficiency, and better outcomes to veterans who have served our nation and fought for our freedoms. We are proud of the first deployment of the system under Oracle's ownership, with the go-live in March of 2024 at the Captain James Lovell Federal Health Care Center in North Chicago. And 4 months later, we continue to be highly focused on it to be certain that our initial success endures. Training was critical to this effort, and we are grateful to the Lovell users for attending training and making it a priority. Lovell was the first site where we used learning labs, and so that end users could work as a comprehensive care team to understand the needed workflows. The learning labs were first piloted at Lovell in December of 23 for a small group of 54 super users. Based on the overwhelmingly positive feedback, VA asked us to expand their use, and we quickly stood up an additional 55 sessions for more than 200 end users. All of this led to Lovell's users demonstrating faster adoption rates and less time spent in the EHR than any of the other previously live sites. And we believe that this will contribute to better end user satisfaction. At Lovell, emergency department average weekly patient volumes increased by 14.5% over pre-deployment averages, with total length of stay averages decreasing by 7 minutes. Ambulatory patient volumes range from 70 to 90% of pre-deployment levels, which is consistent with other complex facilities 4 months into a go-live. As Lovell strives to ramp up all department volumes to 100% by this October, we will continue to provide in-person, on-site support for users. Other updates that we have made, both recently and over the last 2 years, have resulted in significant improvements across all live sites. Most importantly, the system reliably runs without outages. We have made approximately 1,500 configuration changes and 88 workflow updates to simplify the end-user experience. We are connected with 90% of community care providers, which provides for better coordination of care. We are working with the VA on improving productivity and revenue collections at the live sites, which of course were impacted by the Change Healthcare cyber attack. We are pleased with the progress VA has made to streamline governance and decision-making and their ongoing commitment to this effort, which will be critical towards driving a consistent standard of care and completing additional enhancements to improve the user experience. In addition, we are planning to move the system to the cloud at our expense. Moving to the cloud will provide even better cybersecurity protections and allow VA to bring forward innovations like our AI-driven clinical digital assistant to help providers take advantage of modern technology to spend more time with veterans and less time on time-consuming data entry. We strongly believe the success of Lovell and the cumulative effect of the various improvements delivered to the 5 sites during the reset, including technical performance, workflows, training, pharmacy, support and clearing tickets, and more, provide the proof that the VA needs to implement the new EHR to additional facilities with confidence. In parallel to ongoing enhancement efforts, pre-deployment work at future sites should restart this fall, and new deployments at those sites should be planned for next year. Oracle is ready to get restarted and to bring the benefits of this new EHR to move more veterans to more veterans across the country. Thank you, and I look forward to answering your questions.
Thank you, Ms. Verma. The written statement of Ms. Verma will be entered into the hearing record. We will now proceed to questioning, and I will recognize myself for 5 minutes of questioning. Dr. Buckley, your facility is performing better with the Oracle Cerner EHR than the previous 5 medical centers. This seems to be because of your hard work and a lot of outside help, not improvements to the system. I understand you got a temporary support from nearly 800 people, and you're on track to add at least 216 staff at a cost of $26 million annually. Could you operate without these resources, and how would the system need to improve so you no longer need those resources?
Thank you, and I think that's a fair characterization and summary, but I will tell you, I think it's necessary for being the first site to go live in a couple of years, that we had those resources brought alongside of us to make sure it was as successful. We are learning that over time that the amount of staff that it will take does not appear to be quite as large as what you just quoted. I can't give you the exact number at this point.
So you don't have a request in to get an additional 100 staffers?
We currently have a total of well over 200.
But do you have a request in right now to get an
We have the
additional
authority-
100?
Yes, sir. We have the authority to hire to that, but what I'm
So things clearly then, Dr. Buckley, okay, things are clearly not functioning exactly right, or you wouldn't have a request in for an additional 100. So could you currently operate without those resources, and how would the system need to improve so you no longer need those resources?
Well, I can tell you, yes, I think we could. I can tell you this.
Can you operate without those resources?
We cannot operate
Okay.
and to meet the needs of both departments, to make sure we're delivering the care.
Okay, so
and learning
you could not operate without
at this
those
point.
resources,
That's
correct?
why we're asking for them, the authority to hire.
Okay, so what would need to change? What would need to improve so that you don't need those additional resources?
Yes, sir. So one of the things is over time, learning the workflows within the Oracle Health Cerner Federal EHR. That is a hard task, and that takes time, and that takes time for each facility. I think it'll, as we...
Okay, so how long are you
And then
anticipating you're going to need these additional resources?
What we're looking at right now, and I do want to talk about resources if I'm given the opportunity. So our staffing, one thing to be clear is while it may...
Dr. Buckley, this is my time. I've got 2.5
yes,
minutes,
sir.
so please, okay? How long are you anticipating you're going to need these additional resources?
I would say at least through the end of fiscal 2025.
Okay, so by the end of fiscal 2025, then, when we start working on the appropriation bills, then we're going to be able to make an adjustment so that these additional resources are not directed?
I think
And we're not going to hear complaints from you or your employees?
Well, I complain a lot.
Because I've got a chart back here where everyone was telling me that we're going to stay within the $16 billion, and we clearly aren't going to be able to do that. Dr. Buckley, you had 808 joint patient safety reports 3 months after Oracle Cerner went live. How crucial are these additional employees to mitigating the system's safety risks?
Well, I think the more focus that everyone has on being a high reliability healthcare organization, the better. I don't necessarily think throwing more staff at a problem is the solution.
Great, so that means we're going to be able to start
And I
reducing
think
these staffing
in
then.
In time, I
So
think
can
we're
I
able to do
then,
that.
or can we expect that you're going to remove that request for the additional 100 staff that you have outstanding now?
No, like I said.
Okay, so we still do need staff for that. Dr. Buckley, you described your facility's experience using the Oracle Cerner EHR to the committee staff as a pitched battle, but prevailing. What makes it a pitched battle, and how are you prevailing?
Well, I would say healthcare delivery is a pitched battle every day because we can never, ever be fully at the place.
Okay, but how about your facility with the rollout of a new software program? Why is that a pitched battle, and how are you prevailing?
Well, I would say that adoption of a new health record and a change of this magnitude is no kidding hard. It really is hard. But I think our staff know that the battle is worth it in the long run, that this is going to deliver the conditions for standardization that the VHA needs, and that modernization is something we need in order to reach standardization.
Thank you very much, Dr. Buckley. My time has expired, and I will now recognize Ranking Member Surface McCormick for 5 minutes of questioning.
Thank you, Mr. Chairman. Dr. Buckley, Oracle's testimony paints a fairly rosy picture of the pharmacy at your facility, but when my staff was there in June, they heard very different things. How are dispensing volumes and wait times now compared to pre-go live?
Thank you. There's a great question about the pharmacy. I will say, don't think rosy is a great word, but I think that acknowledging our pharmacy staff at Lovell FHCC North Chicago is worth mentioning. They have been tenacious in understanding what the requirements would be. This is a lot harder. Remember, this is 2 separate pharmacy benefits, 2 separate formularies dispensed side by side. And so the challenges, and pharmacy is probably the biggest one, the challenges to modernizing with this health record are pretty substantial. And I was surprised how well this federal EHR was actually able to perform when it was delivered.
Now, you mentioned your staff. About how many staff members did you have to help you get to this level?
Well, when we started pre-deployment, we had, I'll say, roughly 140 full-time pharmacy and pharmacy techs. I will say, actually, right now, we have actually less full-time pharmacists and techs on board right now than we did when we went live.
So what was your maximum amount? You said when you started, you were at 140. What was your maximum amount?
Right. So I'm going to have to take that one for the record to say precisely how many additional staff. If we're looking for part-time additional FTE that helps with that, we have benefited from NESU, the National EHRM Supplemental Staffing Unit. They're providing, I'll say, roughly 4 to 5 pharmacy FTE per day, and that's the additional value that they bring for outpatient. What are
So what would be your total
outpatient
range? Your total range of staff that it took for you to actually achieve this result?
I'd have to get the top value on that from pharmacy itself, but I would look to where it was somewhere less than total staff of 150.
Dr. Evans, we're hearing that the 3B and 3C upgrades have been pushed to next spring. We're hearing from pharmacy staff that these solutions are desperately needed. Why have these fixes taken so long?
We're anticipating that the pharmacy, what's known as the pharmacy 3B, 3C upgrade, this is the capability that will keep the ordering, the system that providers order prescriptions in sync with the system that pharmacists fulfill the prescription in. That is going to be delivered in February of 2025.
But why has it taken so long?
I think in some ways, it was delivered numerous months ago, and there were findings on testing prior to delivery of the 3B, 3C capability, where a subset of what we expected the synchronization to do did not work. A small amount, but a significant amount. And we made the decision to not deploy it until it was as we wanted. We've spent a lot of time really getting...
I have another question, so I just want to get to this. When did you provide VA, when did VA provide Oracle with the requirements to fix these issues?
We had a joint meeting that was, I think, a few months ago, a month and a half ago or so, where we sat down actually at the facility in FHCC, national pharmacy leadership.
Thank you. Dr. Verma, from Oracle's perspective, what has been the holdup in fixing these issues?
Sure. Well, just to give some context of the whole pharmacy solution, right? So the way that the pharmacy operates is very different than what we see at most commercial sites, and so it's required some unique configurations. VA had asked us to focus on pharmacy in particular. There were 7 enhancements that they asked us to make. We delivered 6 out of those 7. We thought that they would take much longer, but they were actually delivered in a year and a half, which was much quicker than originally anticipated. We thought it may take 3 years, but we were able to deliver that quicker. In terms of 3B and 3C, we did deliver a solution, as Dr. Evans indicated, and I think through testing, there was the thought from VA that maybe a different design would be better. So we have been working together. I think the teams went through requirements and redesigned something that we think will work better, and that'll be delivered early next year.
Thank you so much. I yield back.
Thank you very much, Ranking Member Surface McCormick. I now recognize Representative Self for 5 minutes questioning.
Thank you, Mr. Chairman. Dr. Evans, I'll be honest with you. I've been asking, we're talking about tactical issues here, symptoms, how fixes to things happen. In my questioning on this system, I've asked, where is the value proposition? Because it normally is savings, cost over time, supplies, maintenance, sustainability. And nobody can tell me what the value proposition is. Why are we doing this? Now, in your own testimony, there were some very soft phrases which should, over time, positively impact patient care, quality, and safety, more coordinated experience for VA staff and clinicians, improved operability with the rest of the American healthcare system, and then what looks to me, and you make a big point out of it, transitioning from DOD to VA, but that looks to me to be a one-time event for most people. Do you use life cycle cost analysis?
Yes.
How are you accounting for all of these personnel that you're adding in your initial, way back when, your life cycle cost analysis? Because let me just refresh you. We're $35 trillion in national debt today. Every dollar in discretionary spending, everyone, all those that we vote on, 12 appropriations bills, every dollar is borrowed in discretionary. You've got a $12 billion shortfall, 15 across VA. And you tell us that something on the order of $50 billion is going to take to finish the rollout here in 2038, I think is what you say. So I think most IT systems, everybody knows that once they're deployed, they're by that time overpriced, obsolete, and behind schedule. So what's it going to cost us to finish this rollout with a complete life cycle analysis?
So when this program first began, there was a life cycle cost estimate. And that's where the $16 billion number comes from that was referenced earlier. That includes a significant investment in infrastructure that was necessary to run the electronic health record. And in that life cycle cost estimate, we also did not include costs for the sustainment of the system over time.
Now, why not? Because sustainment, when you buy an aircraft or a tank or anything, sustainment is a major part of the life cycle cost analysis.
Right. And you've referenced a number, a higher number that was based on work that was done by IDA, a separate life cycle cost estimate outside the program, which did include sustainment costs and, frankly, a longer tail to the life cycle cost estimate. And what we've said is that we agree that a life cycle cost estimate is critical for this program. At this point in time, without a deployment schedule, it's hard to deliver a revised life cycle cost estimate. But one of the things that we've said is that as part of this reset, as we move towards restart and a new deployment schedule, that we would deliver a revised life cycle cost estimate.
So you started with 16 billion, we're however many billion in it now, 9 or something, with another, staring down the barrel of another 50.
I don't know where the number 50 billion comes from, but I think that this is part of why we do need to, as part of the reset, understand what the life cycle costs are going to be as we move forward.
So there are estimates, apparently there have been estimates done that in some of the live sites, we've got to go quickly here, we're looking at a 20%. In some of the live sites, we were looking at a 7% increase So if we go with the high end of that, it'd be 10 billion more that's not accounted for. If we went to the low end, it'd be 3 billion more. So I'm going to be curious in the future, rather than talking about these tactical issues, these fixes on the things that we see in front of us. Where are we going strategically with this thing? Because I don't see the value proposition over the life of this thing. We've got, and Dr. Buckley here, as he eloquently said, he leads the only integrated site, so I don't think that's even a good test bed for us to go to the single site that has the very successful DOD program and the less successful VA program. So with that, Mr. Chairman, I yield back.
Thank you very much, Representative Self. I now recognize the chairman of the full committee, Representative Bost.
Thank you, Mr.
On this
Chairman.
question.
Mr. Duke, over the last weekend, Congress received a request for supplemental funding to cover the benefit shortfall that VA expects in September. When you put the supplemental funding request for health care next year, shouldn't it address the staffing costs related to the HR?
So it does assume a higher level of staffing for numerous purposes, to include the emergent needs of the go-live sites.
Okay. VA has been indicating since February that there may be a health care budget shortfall driven by community care. But community care only accounts for 1.8 billion of the 12 billion shortfall you say you have. When did you realize you have had a much wider shortfall on your hands?
When did we realize? So I would say when we were monitoring FTE counts beginning in the January time period, as we started to watch where the staffing levels were, and when the staffing levels were coming in higher than what we were targeting, similarly, the year-over-year growth of community care obligations was higher than what we had projected at the time of the budget.
That was not given to us. We kept hearing that we're fine, we're fine, we're fine, we're fine. So how much of the 12 billion estimate shortfall is due to hiring?
Is due to hiring? Hang on, let me pull the number. It's roughly around 3 billion.
Okay. How much is the medication shortfall and the prosthetic shortfall, and what's exactly is driving those costs up?
So in the 5 billion, in the 25 period, we've seen an increase in prosthetic and the costs that are actually being paid by our facilities. So we put in, I think it was 3.9 billion, and to assume a higher level in 2025 that's associated with those costs. And we are still diving into those costs to see what's driving them.
Ms. Verma, I've got another question for you, and not so much a question, but just a statement. When this all was going on, and I was ranking member, not yet chairman, and we were watching Cerner blow apart, okay? Oracle came in and they made their purchase. And they came into my office and they had about 3 or 4 executives. Wasn't the primary owner, but a lot of the upper echelon. Now, you told me that, or you told us just now about the pharmaceutical, that there were 7 unique situations put it before you. You could get 6 of them done, and you did them in 18 months. Now, I'm going to tell you exactly what your executives told me in that room whenever they were taking over for Cerner. If a person tells you in this industry that they can't fix a problem in 6 months, they don't know what they're doing. That was their exact words. I wrote it down. You're telling us to fix the situation with the shortfalls and the problems that have occurred in the pharmacies. You've been working on it 18 months, a great thing, because you got 6 of them done. But every time we turn around, and I've said this before, the frustration level that I have felt and being on this committee, and through 2 administrations now, and the lack of being able to get this done. And I have to agree with my colleague, Mr. Self here, that comparing to where DOD is already working, and then being able to wave that as a flag that you're doing well, when every other one that strictly deals with VA has failed and failed miserably, and the only reason the only reason that Great Lakes and that area was done is because they offset it with staff that they used through DOD to help them get it done. This is very difficult trying to do our fiduciary duty every time we call you guys in, and we keep getting one reason after another, after another, after another, that we can't get things done. Now, that was directed at you. I don't need you to answer the question. I'm just telling you the things and the frustration that we're feeling. I'm going to leave it to the rest of the committee to keep asking questions. I don't know how to fix it because we're so far down the road that we can't put on the brakes. And the bad thing is it should have been very simple to adjust, and now here we are, not slightly over budget, way over budget. We only have 6 facilities, even started to be turned up. And this has been a boondoggle from the very beginning, and I'm very disappointed, but with that, I'm running out of my time, and I yield back.
Thank you very much, Mr. Chair. I appreciate you joining us today. We're going to go to the second round of questions, and again, I'll recognize myself for 5 minutes. Dr. Buckley's VA testimony states that you are 70% of normal outpatient productivity since implementing the EHR. Dr. Evans stated 80%. So we have a discrepancy there about who's using what numbers. Where are you exactly throughout the whole hospital today?
So through the whole hospital, if you looked in our what I'll call the inpatient, as I said, side of the house, so the bedded part of the facility, the ED, the ORs, I'd say we're upwards of over 95% production in those areas. Our 32-bed locked psych unit has been at 100% since go live. Our med-surg unit and ICUs are now virtually at 100% capacity. I think we're 1 or 2 beds down still. Our ED, as we mentioned, was never missed a beat to go live. So I would say in those areas, if we mix that with the outpatient, those the ambulatory clinic visits, we're sitting at right at about 80% using the focus metrics that have been provided.
Okay, so if we're sitting at 80% on the averages, and you're telling me that you're at 90 to 100% for your inpatient, then the outpatient must be dramatically lower than that.
No, sir. The average of the outpatient, if I misspoke, I apologize. The average of the outpatient that's being given to us right now, where we're sitting, is roughly 80%. There are some areas some clinics that are less than, around 70% or less. There's some that are well over 90% in the clinic environment.
Okay.
So where we're sitting now is about 80% in outpatient, close to 100% on everything else. And that doesn't include the DODs. Remember, we are the lead agency. And we, unlike what Chairman Bose said, the DOD did not give us extra staff. We have less staff from the DOD. That bill comes to us, and then we have to bear that. And hopefully
Okay, I understand your staff have the same basic struggles with the Oracle Cerner system as the other medical centers' employees. That's the feedback and the report that we've received. On top of that, yours is the first large complex VA facility to go live and has revealed some new problems. Will you please explain the patient movement problem?
I'll do the best I can, sir. The Oracle Health Cerner model has what's called an encounter a FIN number, a financial number that gets attached to the patient when they first enter the inpatient environment. And those inpatient environments could not only the meds, a inpatient hospital unit, but it could also be our CLCs, our skilled nursing facility. It could also be our residential substance abuse treatment areas. Those all enter under the same FIN. And when that patient moves around the facility, typically in a private sector environment, they would go from an external facility to a facility that might be using Cerner. They would get a FIN, and they would work through that acute visit, and then go home, go back to the nursing home, go back to the rehab, go home. In this case, that FIN follows them around, and we have to be extra mindful that the beds need to be secured for them. There needs to be standing orders that get held in a leave of absence status. So that causes a lot of strain. The good news is that partnering with the program office and VHA, we're really coming up with the best policy for the agency to address this problem, because frankly, the DoD didn't have this problem. There's a lot of complexity that the DoD doesn't have to struggle with. And this is a great example of one.
Okay, please explain the situation with the power plans, which are basically templates and checklists in Oracle Cerner that are supposed to save the stay of time.
Yes, sir. I think the long and short of it is that power plans are order sets that are best done when there's clear standardization and that it comes from the councils and program offices that understand what orders need to be provided and which don't. This is really something that's probably one of the best things that this modernization can do, is to bring standard order sets, standard power plans across the organization, and so that when you go to one VA, you could go to another VA and still sit down and have the same choices to choose from, or when you write orders for a typical problem, if you're admitting a patient or you're giving patient chemo, whatever.
Now, I'm going to squeeze one more question in before the clock ticks down. Have you identified solutions for the patient movement, prosthetics, inventory, and power plans problems?
Well, sir, we just had a big meeting this week where we brought in tons of subject matter experts that are attacking that problem. And again, a lot of the struggles with that movement comes across from DoD's process versus VA process. VA has a much more exacting process to have accountability of prosthetics and implants and tissue management.
Okay, I have expired my time, so I'm going to yield and recognize Ranking Member Surface McCormick.
Thank you. Dr. Evans, Oracle seems to be blaming the systems collections failure on the Change Healthcare cyber incident, but Millennium has struggled with expected to observed collections since the first go live in 2020. Is that a fair assessment of the ongoing issue?
A portion of the revenue cycle issues or delayed revenue collections has to do with the pharmacy co-payments. Approximately 50% of the delayed collections are related to pharmacy co-payments, which were not initially collected at the initial go-live sites because of some issues that needed to be sorted out with the system. That problem has been solved technically, and pharmacy co-payments are being collected through FHCC, and there have been no issues with that.
And what has been the impact of the inability to collect the co-payments and the third-party payments on the VA's budget?
The impact on the VA's budget. So I think in many cases, the impact is essentially not that we won't be able to realize the revenue, but that the realization of the revenue has been delayed. And so I think Ms. Duke may have some thoughts on that.
Yes, so as part of the Change Healthcare, we had a wider issue with delayed collections. So part of what we've been able to do is provide funds out to the medical centers based on expected collections against the anticipated carryover into 2025, but we are not identifying that as part of our shortfall because we fully expect that come 2025, we will be able to collect on these outstanding requirements.
So for clarification, you're saying that the problems with copay and collecting third-party payments, they are based off of the Change Healthcare incident?
So other than the pharmacy issue that Dr. Evans mentioned, which was a known issue, and honestly, the delay in restarting the collection has been to make sure that we communicate adequately with the affected veterans and make sure that they understand the bills that will be coming their way.
But Millennium it hasn't been able to collect. So what impact has Millennium had on it?
So the data that is coming available from that was not necessarily always in the form that we needed it to be, but I would say that we've always somewhat struggled with meeting our collections, and we continue to work collaboratively with the EHRM office and to ensure that we receive the data that's necessary for our collection staff to do their
Okay.
work.
Dr. Evan, we've been talking about concerns about copay collections for a while. I hear that the VA is now or is preparing to begin collecting. How far back are you collecting for sites that haven't seen since their go live?
The initial collections will be from this point forward, so we will start to send out bills for the,
This point as far as long, today is this point?
when we restart pharmacy copayments, those pharmacy copayments will restart month to month with a statement for that month's charges. We, as a subsequent effort, will look to evaluate what the retrospective billing back to the original go-live would be, and we'll, of course, be communicating with veterans about their, what options are available to them to assure that they're able to manage those co-payments or apply for waivers or whatever benefit might be available to them.
Would you be able to give me a range of how much money has not been collected from the copays and the third-party billers?
I can't give you that right now, but I can certainly take that for the record and be happy to brief your staff.
Wonderful, and as I have a few seconds left, can I get your assurance that no veteran will experience financial hardship due to back collection or of copays?
Yes.
Thank you, I yield back.
Thank you very much, Ranking Member. I now recognize Representative Self for another round of questioning.
Thank you, Chairman. So let's revisit some of the costs. You said there were 16 billion, your initial estimate. We're some 10 billion into it now. You didn't like my 50 billion, so why don't you tell me when we reach 2038 or whenever it's fully rolled out, what would your estimate be?
I don't have an estimate that I can provide you. As I mentioned, that would require us to have a schedule for what the further deployments are going to be.
Well, let's assume you roll out, when do you want to start? August?
We've said that we'll restart pre-deployment activities within FY25.
Okay, so 25 to 38. Do you have an estimate?
I do not.
Okay. Dr. Buckley, and my question to you, Dr. Evans, is when are we going to see some ROI? In terms of any of those soft things you had, either cheaper, faster, better, however you want to quantify those, where do we see some ROI? Dr. Buckley, apparently y'all hit 90% productivity back in April, but it led to burnout on your staff. So you're getting all of these extra personnel to help you, but then you just told the chairman that you don't need them going forward. So what happens after they leave? What percentage are you going to be able to reach with the staff that you'll have at that point?
Well, I think my comments I want to clarify. I'm not saying we don't need all of them. I'm not saying we need what number precisely at this point we're going to need, but we're committed to make sure that we only bring on board those that we absolutely need. And as we move forward in time, we're starting to get a better estimate of that. There's a couple of important things.
Yeah,
Yes, sir.
let me make a point about that, because this system has been described to me by one person. Is the example would be we used to have airplanes that took one pilot. We've got a higher technology plane now that takes two pilots. I was going to use the analogy of I hope we're in the courting stage of this relationship between VA and Cerner. But given the Chairman Boss comments, we may be in the early marriage stage where we are too far committed, and yet we've just lifted the veil and now we're seeing what we actually have. In either case, I think we've got some work to do. I want to address customization, Dr. Evans. Some people believe DOD did so well because they didn't allow a great degree of customization. And between the VISNs, VA is allowing customization with no minimum standards. Can you address that? Because if we allow customization for everything, one, it's going to be more expensive, and two, eventually it won't be interoperable or seamless.
Yes, absolutely. I would love to address this. I think this actually gets to your earlier question about what the value proposition is. One of the most significant value propositions of deploying the federal EHR is, in fact, our ability to have a single instance of an electronic health record that allows us to deliver a single best practice standard of care delivery across the enterprise.
And how does customization fit into that?
It doesn't. And I think one of the things that we saw that is a story that I think we should celebrate from a success perspective is that in many ways at FHCC, we were able to deploy what is the standard, what is becoming the standard deployment. So I'll give you an example. How you name clinic locations in the electronic health record, whether it's a primary care clinic, a rheumatology clinic, an orthopedics clinic, the location of that clinic, how that is rendered in the electronic health record needs to be standardized. Otherwise, how do you find the location where you're going to order something? And we were 100% compliant with the new standard at FHCC, which is very different than the prior 5 sites. And we're now going back to fix the prior 5 sites and to bring them into the standard.
Chairman, I yield back. Thank you.
Thank you very much, Representative Self. Ms. Duke, we're going to start talking math. As of June, Dr. Buckley was waiting for the VHA central office, presumably that's you, to release additional funding so they can hire the rest of the 216 staff that they've determined that they need. Sometimes we're being told they don't need them, but they can't function without them, so I would say that they need them then. Has that happened, and if not, when will it happen?
I believe the funding has gone out. If it has not, it will be by the end of the month.
Okay. Ms. Duke, several of the departments at James A. Lovell say that they need even more staff to keep their heads above water, particularly medical support assistants and pharmacists, which don't seem to be budgeted at all. Are you able to provide those resources?
So we would not provide those resources from the central office, but we are communicating with our VISNs to make additional funding available, but that is part of the identified shortfall that we've been in communication with you about.
So, Ms. Duke, conservatively, James A. Lovell is on track for a 7% staff increase so far to mitigate the Oracle Cerner system's impacts. And the Spokane Medical Center had to increase their staff by over 20%. If the system was rolled out across the whole Veterans Health Administration, based on the current payroll, that would mean between $3.5 and $10 billion in increased staffing costs, which is reflected here on this chart. That's on top of all the costs to purchase and implement the system. And that's just my back of the envelope math. But you need to know the amount down to the penny. That's what your obligation is. Have you done any study or estimate of those costs, and have you budgeted for them?
We have not done those costs at this time. We are working with the EHRM office on the as we come out of the pause to ensure that we align our future resource requests with the requirements.
Will you commit to doing a study of the financial impact of implementing the EHR throughout the rest of VHA before the system is installed at any more facilities?
I will commit to working with EHRM office on identifying the resource requirements and aligning our budget requests accordingly.
Okay, well, we would really like to have those costs before we have conversations about rolling it out at other facilities. Ms. Duke, you informed the committee last week that VHA expects a $12 billion budget shortfall next year. Secretary McDonough testified in April that he plans to resume the Oracle Cerner rollout next year. How can you possibly justify introducing this disastrous system into more hospitals and diverting staff and resources when you're already in a serious budget crisis?
What I would say is that I will identify the necessary resources to implement the delivery of care consistent with where my organization chooses to go. And if we do move forward in 2025, we will look at the requirements and ensure that they are possible within the available resources that we have.
So we're already running a $12 billion budget shortfall in VHA. I'm trying to figure out where are those additional funds going to come from, because we already have the additional staffing requirements that we have seen. We see that on average, you've got somewhere between 7% and a 20% increase in staffing. Where is this additional revenue going to come from?
The identified shortfall that was communicated in part was in response to the recognition that we were not going to be able to achieve the lower staffing level that the original budget estimate had included.
I understand that. It's a shortfall. It's a $12 billion shortfall, okay? And when you already have that, I'm trying to understand how we're going to address. The EHR has thrown Vision 20 into a permanent budget deficit. And Vision 12, Representative at Lovell, warned committee staff that they don't have the resources to support more than one medical center implementing the system over the course of the year. That's for the Vision. They don't have the resources to support more than one medical center. How much will resuming the EHR rollout cost VHA in 2025 and 2026? And how are you going to find the money to pay for it?
Again, I think I would echo Dr. Evans that the identified cost will be contingent on the identified plan, and that we would communicate our requirements in the 26 budget according to our practice to make sure that we're adequately resourced for whatever the plan ends up being once we do come out of reset.
So you're going to come back and ask for more money?
I think the other thing I would add is that though we fully acknowledge the staffing increases that have been necessary at the sites to date, we anticipate and our aim as we get better at using the system, as we increasingly standardize, as has been discussed, is to get to a point where we don't require significant additional staff in order to implement the system.
I understand that that is your hope, and I understand that that is your goal, but it is not reflective in reality, Dr. Evans, okay? With that, I have expired my time. I'm going to yield to Ranking Member Sheriff McCormick for 5 minutes questioning.
Thank you, Mr. Chairman. I wanted to go back to talk about the pharmacy copay issues. Do I understand correctly that we're looking at billing back to 2020 at the Mann Grand staff?
As I mentioned, we are going to restart from time forward. We anticipate and are looking forward to briefing your staff on considerations with regard to co-payments with regard to prior co-payments and the approach to that.
So that's a yes. You're going back, you're going to start billing from 2020, is that correct?
We are working on a plan with regard to how we will address prior to current day.
Okay. And so I think we need to have a bigger conversation about that plan.
Of course.
Our concern is becoming that we don't know how it's going to impact our veterans going all the way back to 2020 without those co-pays, and if it might devastate them. So once you have a plan together, we would like to talk more about that plan to ensure that
Absolutely.
our veterans aren't being devastated financially.
We
economically.
fully intend to speak to the staff, and that's in part why we're not starting with anything that is retrospective or in arrears. We're looking only at time going forward at this point in time.
Wonderful. I did want to go back to also the Change Healthcare situation. Is currently the VA's plan to reconnect with Change Healthcare or seek another vendor?
I believe our plan is to reconnect with Change Healthcare, but of course, as part of our commitment to moving forward.
So what remains to be done to either reconnect with Change or another vendor to resume the collections? Well, I think it's going to be with Change, so what's required? What remains?
So my understanding is that we are working on the ability to reconnect to the clearinghouse, and we had been identified that that would be completed by August of this year.
So by August, you expect that'll be done?
End of August, yes.
How confident are you that once Change Healthcare Issues has been rectified, Oracle's system will be fully capable of appropriate collections?
Based on the data that we've seen so far, we are fairly confident.
And so now, Dr. Evans, I have another question for you. Actually, okay. What matrix do you plan to use to determine when it's time to restart or go live activities?
The decision to restart pre-deployment activities, and again, I'll remind you that that's just preparing a site for go-live. It's not an actual go-live. There's a 15-month period of time between when we start that work and when we actually go live. Will be a leadership decision that is driven by and informed by data. We're evaluating 4 different categories of data to understand and help us make that decision. The first is the end user's experience, whether that be one of our staff or veterans. The second category is about our healthcare system operations. We've talked today already about productivity, revenue collection, and other matters that are part of our health system operations. The third area is about the stability technically of the product. That is, that it is working reliably without outages or significant hangs, crashes, or lags. And then the fourth area is looking at our program processes, how we're managing change, how we're delivering on our commitment to standardization through this project.
I believe you mentioned user satisfaction. What role does user satisfaction at the 6 live sites play in your decision-making, and how do you measure user satisfaction?
User satisfaction is critical. I think you're well aware that we have recommendations from GAO with regard to change management and user satisfaction that we are considering very carefully as we move forward. As part of our commitment to better understanding user satisfaction, we've increased the frequency by which we are surveying our users. We are using a standardized instrument that allows us to have comparability with private sector healthcare organizations as well as with the Department of Defense. That survey is being done more frequently, at the moment, approximately twice a year.
So while I have a few seconds, I just wanted to know, what is the threshold you're looking at before achieving restart?
The threshold, I think what's critical for restarting pre-deployment activities is that we see trends moving with, and not just in a small way in a positive direction, but a positive, consistent trend with regard to user confidence and user satisfaction. Again, we will continue our improvement efforts as we then are preparing to go live again. So what we really want to know is, are we moving in the right direction with regard to user satisfaction?
Thank you. I yield back.
Thank you, and I recognize myself for 5 minutes now. I want to get into the pharmacy, okay? But before I do understand, Dr. Evans, that we will see a request. I just want everybody that's watching to understand this. We will see a request for $12 billion to cover the shortfall in VHA.
I will defer that to Ms. Duke.
So at this point, we've communicated the need, and I would defer to the Office of Management and Budget on the way in which any request would come over to the Congress.
Okay. All righty, I want to move to the pharmacy here. Please don't filibuster any of these because we have some issues to get through here. Obviously, Dr. Buckley, there are problems in your pharmacy, and I think the pharmacy organization within the VA recommended you not go live. Can you explain the new difficulties that you're having with a community living center and then mixing DOD and VA patients? Would you just quickly do that?
Sure. I don't really have a good response for you for community living centers precisely, so I'd have to get some more specifics on your question. The joint, as I mentioned, the joint VA-DOD deployment involves 2 separate pharmacies, 2 separate benefits, and the need to, at the window, to understand when the patient comes to the window, which benefit they're going to use. We've struggled with that in the past, and it's much, in many ways, for the providers, it's much better.
Okay, we've I think we've been over this, but just real quickly, how many worked in your pharmacy before Oracle Cerner went live? How many have you added, and how many more will you potentially need? 3 figures.
Yes, sir. Like I said, for precision, I'll take it for the record, but I'm going to give you the figures. So before, 140. Currently, permanent staff, 132, down. Additional NESU support, 5. So that puts us, math for doctors in public, at 139. So we're still a little less than we started at baseline if you look at FTE. Now, I'll talk about that. There's overtime, there's other factors, I agree.
Okay, so your figures are different than mine, which are 140 FTE. Previously, you've added 24 FTE, and you're waiting approval for an additional 41 for a 46% increase. Those are the figures we have.
Yes, sir.
So
Take it back.
you're able to, with all of these additional FTE, you're able to produce about 40% of your normal workload. You're relying on National Supplemental Staffing Unit to handle about 50%, and then other pieces of the VA are pitching in for the the remaining 10%. Is this acceptable, sustainable? How are you going to move forward?
I think it's necessary, and I think the things that we are working on now to improve this CHR for the rest of the VA and for us is an investment that's well worth it, and I think the additional FTE up to what we've asked for may be necessary. We're looking hard at that, like I said, every couple of weeks.
Okay, so Dr. Evans, he needs something up to and including 46% increase in FTE. How many pharmacists and technicians are available in your supplemental staffing unit for the whole of VHA?
I don't actually know the specific number who are in the supplemental staffing unit to support pharmacy. At the moment, the vast majority of resources from the National EHR supplemental staffing unit are able to be directed towards the facility in North Chicago, they being the most recent to have gone live. This is part of our projections as we plot our path forward to make sure that we're adequately resourced to supplement staff with regard to restarting with deployments.
Could be significant, though. Okay. And Dr. Buckley, you had a glitch on controlled substances. How are you mitigating that risk?
Well, that's another example where we have to have hypervigilance to the workflows. One of the big benefits to the Oracle product is they can track every single click that was ever made, and if there's any nefarious activity with diversion, ultimately that's going to be detected.
I was in one of my hospitals just last week, I think, and they explained their system to me, a very sophisticated barcoding on everything, the drug, the patient, the distribution system. This can be done. And Ms. Verma, can you explain what the Pharmacy 3B, 3C software update will do exactly?
Yeah, so 3B and 3C, when implemented, it kind of creates that closed loop system. So if the pharmacist doesn't have exactly what the physician prescribed, then they can make modifications based on what's available. And that change will be reflected back into the electronic health record so that the provider can see that change as well. That's what we're working towards.
Will that fix the problems that he has?
It should fix some of them. I think whatever we kind of put in 3B and 3C, it'll address the problem that I just described.
Okay, thank you.
Thank you. Ms. Verma, Oracle's written testimony to its improving usability of the system as a notable focus of the reset. What sort of efforts has Oracle undertaken to improve usability of Millennium at VA?
Sure. Well, that's something that we are very much focused on. The end user experience is top of mind. One of the things that we've learned from our interviews and our time at the 5 sites is that a lot of times when we talk to the end user, sometimes they're not clear on how to use the system. So one of the things that we've done, especially with the Go Live with FHCC, was to increase the training. I think that was critical. I think we also agree that there should be some more effort towards support and more ongoing training, that it's not just a one-time when you're implementing. The other things that we've done from a broad level is that this has been a focus for Oracle generally to improve end users, especially the experience of providers. And most EHRs have kind of focused on, a lot of clicks and reducing the number of clicks. What Oracle is doing from a company-wide perspective is implementing things like our clinical digital assistant, which listens, it's ambient listening, and it can listen to the doctor-patient interaction, can even decipher between casual conversation and between many people in the room to actually produce the doctor's notes and also create orders as well. We have committed to moving the DoD and the VA to the cloud, and by that movement to the cloud will enable the VA to be able to use this type of technology. And that's a type of benefit that the end users will be able to realize over time when that's implemented. And it kind of gives you an example of the benefit of doing a project like this, because it allows the VA to leverage modern technology.
Now, how much improvement would you say VHA staff are noticing and that you've heard from them for the usability of the new EHR?
I think that varies from site to site. There are some sites that have seen more improvements. We've heard from some sites where they say they're actually spending more time with patients and they've actually reduced the amount of time that they're interacting with the EHR. For other sites, it may vary, and it kind of depends on, I think as Dr. Evans referenced, that we have the different VA sites doing different things, and so their ability to adapt and to apply the new workflows and configurations can vary from site to site, and some of them may require more.
And Dr. Evans, could you please answer that question?
Could you restate the question?
How much improvement would you say VHA staff are noticing in the usability of the new EHR?
I mean, I think the answer is they are seeing improvement, but not enough and not quickly enough. And we feel a shared sense of urgency to accelerating the improvement in the user experience. I mentioned in my opening statement some efforts that we are undertaking that we're referring to as big rocks. These are, we've implemented, I mentioned that we've implemented well over 1,000 changes into the system since the reset started. Many of those were simpler changes that addressed maybe several users' issues, but were not big sort of game changers with regard to the user experience. Some of that requires us to revisit some decisions that we made early in the program. Some of it requires us to do some of the hard work of standardization that you've heard mentioned many times during this hearing already. And so together, we are focused on these issues, and we specifically chose them and validated them with the field because the field, our users said, these are the issues that we think would move the needle the most with regard to user experience.
Thank you, Dr. Evans. I want to go back to Ms. Verma. Did I hear you correctly when you said that you're not concerned about the too many clicks complaint?
No, we are concerned about it, and so that's why we sort of moved to resolving that in a way that doesn't require any clicks at all, right? So if we go to something like ambient listening, the doctor would not have to make any clicks at all, but we're very concerned about it, and I think I would agree with Dr. Evans' assessment that the implementation of some of the big rock items will address that, but overall, we're moving to a system overall for Oracle that wouldn't require physicians to do the data entry.
Thank you. I have a few seconds. I just want to make sure I get this question to Dr. Buckley. Several of the systems issues identified by your staff appeared to be more related to providers not entering orders correctly or completely, which I suspect is related to the usability concerns.
Yes, I think one of the things we have learned is that we need to work more on adoption, and we need more multidisciplinary teams that come together to understand what is the precise way to order certain types of labs.
While we're over time, I just want one more second to. Okay, thank you. So proceed.
Yes, there is a need to retrain or reinforce certainly with the ordering providers, with the nurses that take off the orders and scan them, with the lab that receives the specimen. All of those need to come together, and that's part of healthcare operations, and that's it's really up to me. I'm ultimately responsible to make sure that happens and to make sure we're using the workflows right, and then we're establishing accountability to use those workflows.
And what is your facility doing to improve the completion and accuracy of provider order entry? And is this an issue with accountability?
Yes, for both. I think one of the things we're doing is partnering with Oracle is they have good tools that they can identify where are those providers that are struggling most with lots of workflows, but let's say lab order entry specifically. And they can identify who those providers are and provide additional user experience training for them. The other thing that's an impact right now is it's July, right? And what happens in July is new interns, residents that do a lot of the ordering rotate in, and they're learning the right thing to order, whether you were clicking it, writing it, typing it, they're learning it, and sometimes that takes an additional amount of reinforcement. The good news is this product actually shows where that's happening, and it's pretty accurate.
Thank you. I yield back.
Thank you, Ranking Member Sherfilis McCormick. I want to thank all of our witnesses for joining us today. I also want to encourage all of you to think about the consequences of the decisions you make. We often talk about inputs here, what you are doing to the system, inputs. I encourage you to think about costs and outputs because that's what's important to the veterans. And not only in the short term, but the long term. There are many careers and reputations wrapped up in this, and it's too easy to sit in Washington and make up budgets and schedules. But frankly, we have veterans out there that need results. We've got millions of veterans, hundreds of thousands of VA employees that need good decisions. The decisions you're making about EHRM may hobble you for decades to come with these figures that we were throwing around today. I urge you to put your immediate concerns aside and become responsible stewards of the organization. I ask unanimous consent that all members have 5 legislative days to revise and extend their remarks and include extraneous material. Without objection, so ordered. This hearing is adjourned. Of course. I'm not holding my breath.
Okay, well, I'm a man of my word.
Okay.